Okay. Yes, we are now being live streamed. I wish to call this first meeting of the Health Occupations and Long-Term Care Subcommittee to order. We will, except when we don't, meet on Thursdays at 11 or immediately after session, whatever the case may be, to vote on bills, continue discussion of bills, whatever the whatever the bill's merit. We have 3 bills on our agenda for today for this work session, and our staff committee counsel is Lisa Simpson. So the very first bill we're going to deal with is the House Bill 19, State Board of Examiners of Psychologists License and Registration Issuance and Renewals Electronic Means. Delegate Cullison's bill. Counsel Simpson, please explain the bill, and I believe there is an amendment.
Sure. So House Bill 19 requires the State Board of Examiners of Psychologists to issue electronic as opposed to paper licenses or registrations to any applicant who meets the existing statutory requirements. The bill also specifies that a renewal notice will only be sent by electronic means rather than by first-class mail, unless a renewal notice that is sent by electronic means is bounced back, or if a licensee or registrant specifically requests that the renewal notice be sent by mail. There are 2 different separate amendments that were sent. One is an amendment from Delegate Cullison that's changing the lead sponsor to Delegate Woods. And then the second amendment requires the board to send a paper copy of a verification of license or registration if requested. And that was that amendment is Delegate Hills. She spoke a little bit about it at the bill hearing.
And is this amendment acceptable to the sponsor and the board?
Yes,
So I did run it by the board and they were okay with it.
Yep.
Delegate Cullison, or is Delegate
Woods.
Woods? I'm sorry. Delegate Woods, are you okay with this amendment?
Yes, sir. Absolutely. Yes, sir.
Okay. Very good. All right, we will take up, well, should we take up each? Those are the 2 amendments.
Right. I think you can probably vote on them together.
Okay. Given that one is a sponsor amendment, do I have a motion to?
So moved.
Second.
Both acceptance of both amendments.
Seconded. All those in favor say aye. All those opposed, nay. The ayes have it. Is there a motion on the bill as amended?
Move the bill.
Second.
We do a roll call on those, do we not? Or what's
No,
that?
we
This
usually
time,
just say,
hand.
does anyone want to vote against this?
Okay, fine. Thank you.
Count hands. Yeah.
All right, of those members in attendance, does anyone wish to vote no? Okay, it is unanimous. Okay, the next bill is House Bill 26, Health Occupations Practice Audiology Definitions. Delegate Kelly's bill.
No.
No, this is Delegate Bagnall.
Oh, okay, I'm out of order, right? Sorry.
So
Sorry,
House
we're
Bill,
doing House Bill 26, which is Health Occupations Psychologists Licensure Qualifications. Thank you for the correction.
so this bill establishes a second pathway for licensure as a psychologist from the State Board of Examiners of Psychologists. To qualify an individual, this is the original bill, the language in the original bill. To qualify, an individual must have a doctoral degree in psychology from a school or university that, at the time the degree was awarded, had a regional accreditation recognized by the Council for Higher Education Accreditation or the Canadian Psychological Association. Received a postdoctoral respecialization certificate from a Department of Psychology that at the time the certificate was issued had a degree program accredited by the American Psychological Association or the Canadian Psychological Association and completed at least 15 1,500 hours of training and 2 years of professional experience. So there is an amendment that was distributed, and that amendment clarifies that the required training includes a minimum of 1,750 hours in a supervised internship. After the amendment was sent out, it was suggested that the language just be moved to the end of Roman numeral 2, because the proponents of the bill feel that the way the amendment was originally drafted, it would have required the internship to be APA accredited, which is something that I guess either doesn't happen at all or happens very infrequently. So they just want to make sure that that internship is not mixed in with those requirements.
And what is the response of the board, of the sponsor? Well, the sponsor is okay with that change, I assume, Delegate Bagnall?
Yes, thank you, Mr. Chair. We did contact the board as well. We're amenable to the amendment. We just wanted to make sure that we put it in the right part of the code to make sure that we were getting to the intent of the board, which was basically to put in statute what is already in regulations. Is that an accurate assessment, Lorraine?
Yes, it is. Yes.
And is the board amenable to us just making that change in where it is defined?
Correct. As it's stated currently, Lisa, is that correct in Roman numeral 2?
It will stay in Roman numeral 2, but rather than being in line 9, it would be at the end of line 12. So after association.
That's fine. Yep.
Okay.
As long as the language remains, yes.
So the language is unchanged. This puts into statute what is currently in regulation. Is that correct?
Correct.
Okay. Delegate Cullison.
Thank you, Mr. Chair. So Lorraine, I just wanted to check that 1,750 hours. That's that is a common practice across the country.
Yes.
Okay, and that's currently what we require in Maryland.
Yes, that's the internship.
Okay, super. Thank you very much.
Sure.
Given that this came up, and I think in testimony yesterday on a bill, what can the board speak to? How does 1,750 hours compare?
That's your actual internship, your
Other
clinical
hours where
experience.
Committee counsel knows that, the extent.
I'm sorry.
I missed the end of your question, Delegate Rosenberg.
Well, and how does this compare to other boards? And 1,750 hours is how many, what period of time?
It's approximately 2 years of experience
Okay.
of clinical
I'm new to the
experience.
subcommittee, so I'm trying to learn here.
I'm not 100% sure how it would compare to other health occupations and internships, but for the Board of Psychology, this is what is used as the two years, and that 2 years includes the internship and then also the 1,500 hours of post-certification training.
So that's in addition to the 1,750.
Correct. Ends up being a total of is it 32?
Yes,
50.
3,250.
3250,
Yeah.
yes.
Okay, no, that's
And that's what's currently in the regulations.
right. Okay. Any other questions? Okay, is there a motion on the amendment as modified?
Move the amendment.
So moved. Is
Second,
there any objection to this amendment as modified? Delegate
Delegate
Riley.
Riley has a question.
Yes, thank you. Delegate Riley, followed by Delegate Bagnall.
I am sorry, my computer was not working, so OIS was here, so I'm a little late. So can you tell me what bill we are on? I do apologize, not my fault.
I was almost late, so no problem. We're on House Bill 26.
26.
This is the psychologist licensure qualifications.
Okay.
bill.
And then I just heard the very end, so so the amendments that are that I have here, in my packet, is that the ones that she's, Delegate Tracutian was talking about?
Well, with a modification, not a substantive modification, but a bill drafting qualification to move this language to the end of the paragraph instead of in the middle of it.
Okay, all right, thank you.
Okay, is there a motion? Oh, Delegate Bagnell, sorry.
Thank you, Mr. Chair. I just wanted to make sure, because we do have the proponents of the bill who flagged the concern, the technical concern. Just make sure that if there was anything that they needed to contribute or wanted to contribute before we vote on the bill as amended.
Thank you.
They had
Sure.
opportunity.
Is there any comments? Are you?
So-
Looks good
so
to
we're-
us.
Perfect. Thank you.
If you're on here, I believe you are allowed to signal with a hand raised. Does anyone wish to comment from the psychologist? Hearing none. Okay, the bill, we've accepted the amendment. Is there a motion on the bill as amended?
Move the bill.
So
I-
moved.
Did we vote on the amendment, on the amendments?
I believe we did.
Okay, thank you.
Yes.
Okay,
Did we, Lisa? Sorry.
I don't remember you voting on them, but
Okay, the amendments have been moved. All those in favor of the amendment, say aye. The hearing no objection, the amendments are adopted. Is there a motion on the bill as amended?
Move the bill as amended.
Second.
Okay, all those in favor, please raise your hand. That is unanimous of all those in attendance. Thank you. Okay. Third bill, and this one we want to have further discussion. The purpose of today, of its being on today's agenda, is to have further discussion. Is health occupations, practice of audiology definitions. House Bill 401. Council?
House Bill 401 clarifies the definition of practice audiology by, among other things, specifying that practice audiology includes the prescribing, ordering, selling, dispensing, or fitting of a hearing aid or audio integrated device to an individual for the correction or relief of a condition for which such devices are worn. There are amendments and a reprint in your that were distributed by email. The amendments make some technical changes. They strike the references to audio integrated devices. They clarify that the definition of hearing aid dispensing includes ordering prescription hearing aids. And they clarify that specified provisions of state law that conflict with specified federal regulations do not apply to over-the-counter hearing aids.
And can you speak, or should I ask the sponsor of the bill, or anyone who wants to speak on behalf of the bill as to what effect these amendments have, what the substance of the amendments, as well as their effect on support or opposition for the bill? And obviously, those who testified in opposition will be able to speak to that issue as well. But first, I want for the committee to get a sense of what effect these amendments have on support and or opposition to the bill. So who wants to speak in support of the amendment?
think, Mr. Chairman, and I'm driving, so I apologize, I don't have my video on, but I think, tell me if I'm wrong, Lisa, that these are the amendments that we did discuss in the hearing from the stakeholders who were favorable with amendment on the bill. Is that right, Lisa?
Yes.
All stakeholders are okay with these amendments? Is your understanding, Delegate Kelly?
So we had received different,
Or
we have received written concerns from a couple of different parties, one being the hearing aid dispensers. So that's why that definition is now included, and they wanted to make sure it was clarified that they could order the hearing aids. there had been some concerns over the Osseo integrated device and whether or not that was within the scope of the audiologist. So that was also removed. And the amendment that clarifies that the provisions of state law that conflict with federal law don't apply to the over-the-counter hearing aids. That was in response to the Attorney General's office wanted to make sure that this language was not preempted by federal law. There is still ongoing concerns, though. I think.
Yeah,
assume
there is. I'm
Bart-
sorry. Let me interrupt you, Lisa, because I answered Delegate Rosenberg's question, meaning the stakeholders who suggested the amendments are okay with the amendments. The stakeholders who have concerns still have concerns. So I want to be clear about that. That's why
That's
we're
what I want.
discussing it.
Thank you.
We're
That's what I
hoping to
wanted.
discuss
Okay.
them this week. Yeah.
Well, Mr. Chairman, Gil Jen here on behalf of the.
You are recognized.
I'm
Go
sorry.
ahead. Go
Yeah,
ahead.
thank you very much. Delegate Kelly, safe travels. Thank you for your sponsorship of the bill. After the hearing, we certainly heard the concerns from the Hearing Aid Society, and we have no problem with their amendment if they want to use our bill to address very similar, same issue there. So we have no problem with that. Ironically, the Board of Examiners actually.
And that amendment, that is part of these amendments.
That's it. Bottom line is, as the reprint exists this morning, the audiologists are 100% in favor. And I did send to your committee members to address potential concerns and maybe some concerns that were at the hearing. Every word in the original bill that was proposed is in either the FDA letter, which triggered the necessity for this legislation, is actually in 4 other health occupations in the state of Maryland. And committee counsel suggested we also pull some other state statutes. And if you look at the attachment I sent, I'm just going to read one from Colorado as opposed to Alabama, Utah. They use the words that are in this bill. Practice of audiology means highlighted human auditory vestibular system. That phrase, that concept is in this bill. Evaluation is in the Colorado statute for practice of audiology. Treatment, management, diagnosing, and then they go on, treatment and management and prescribing. We have given the committee over 15 state statutes, and these are just 3 that are highlighted that include every word. And because of the FDA, the letter there uses the word order. So we believe there should be really no good faith opposition to using what all the other states have used and what the other occupations that we attached in terms of optometry, podiatry, chiropractors and dentists about diagnosing, treating, prescribing, the et cetera, because that gives us we think the statutory justification, because we're trying to do best practices. And Maryland has the opportunity to put a bill ahead of everyone else that can be the national model for best practices for audiology. So we accept all the amendments that are being proposed and urge a favorable vote as amended. And actually, we think it's such a good bill that has been cross-filed. We would encourage the committee to make this a committee bill and everyone get on. Thank you. Also, just in case.
Can we hear from the
technical-
other folks as to what?
Yeah,
they
just
think?
a technical, Dr. Segev is on as an audiologist as well. So if there are any technical questions, she can address them. But I think she has one comment, why it's important. We need to change the law as it addresses your constituents and patients. Dr. Segev, could you?
Yes, absolutely. Thank you for having me.
You're recognized, Dr. Segev.
Thank you so much. We're just asking the language be updated to be consistent with the FDA final rule. We don't want any interruption to patient care of your constituents, and this does not change our scope of practice. This would just help Maryland be continued best practices for our patients and your constituents. Another point is that many third-party payers have already updated their language, so this would just make everything consistent.
Do we, either from the other folks who wish to test, does anyone wish to speak to these amendments? Ms. Mercado? You are recognized.
Thank you, Mr. Chairman. I'd like to speak to the bill. The amendments we'll look at. I think we still have problems with that section of the law that had been amended, but Mr. Shattuck might be better positioned to answer that, and we may need a little time to look at that since we just saw the amendments. So if it's time to speak to the bill in the other section, which I spoke.
And so what you're saying to us is on the amendments, you haven't had time to review them.
That's right. And if there's some language in there, I do believe Mr. Shattuck may be able to be more specific on that section, but I think there's some prescribing language and other language in there that we have concerns with.
Okay. Mr. Shattuck, on the amendments.
Sure. I guess, and I'm speaking to the FDA guidance letter that the audiologists and their lobbyists pointed to, and being, I guess, the basis for this bill before us. In reviewing the FDA guidance letter, which I don't know if the committee has or not, but we can forward that to your to the committee staff. But the FDA, when they made this availability of over-the-counter hearing aids, which was effective as of October, I think, 22nd, 2022. Prior to that effective date, the FDA sent out guidance to states because there was some confusion about, well, what does this mean? And in our reading of the FDA guidance letter, what it's clear to us is that the FDA defers to the states as to who and how prescription hearing aid devices are prescribed. FDA has their opinion about, what could be done, but they say it's up to the state to define who does what. And quoting from the FDA letter, it says a state can authorize many kinds of practitioners to order the use of or prescribe a prescription device. And then it goes on to say, the relevant requirements for prescription devices apply in the cases of practitioners licensed by the law of the state to use or order the use of the device. So the way that we're reading this is this new policy went into effect, creating a new classification of over-the-counter hearing aids. And the FDA is saying, well, nothing should change in the states. Nothing should change about who can do what. So that's why we have a question about the bill and what is this bill really intending to do. And I think that's where our confusion is. And then also the FDA letter goes on to say that in terms of terminology regarding prescription, again, that's in the purview of the state to define what that is. It does not need to be the term prescription. It could be the recommending or fitting. So again, we're just trying to get a better understanding of what might need to be done or what the audiologists feel needs to be done in response to the FDA.
Council, do we have a copy of that FDA letter?
Yes, we do. And I'm pretty sure it was submitted as written testimony.
Okay, thank you.
Mr. Chairman, may I respond to Mr. Shattuck's reading of the FDA letter?
Yes, you may.
Thank you very much. He did not read the next sentence. FDA's intent is that the same professionals who recommended, selected, fitted, and dispensed restricted hearing aids before the effective date would continue to do so for prescription hearing aids after the effective date. We're a little befuddled ourselves why it's this confusing to the opponents of that word. They're all worried about scope creep. Let's lay it out there. There is no scope creep here. Before October 22nd, it was a restricted device, as the FDA indicated. It is now a prescription device. We have given you the other state statutes that even before October 22nd, use the word prescribe. That evidence is in the record now. We don't see where there can be a legitimate objection. As Dr. Segev said, that in terms of your constituents trying to get their healthcare benefits, the payers now have changed the terminology to prescriptive device. We are prescribing a prescriptive device, no more than we did before. That's what the FDA is saying. That's really what Mr. Shattuck said. We agree. There's no difference between then and now. And that's why we thought this was just a technical clarifying bill. But it seems that the opponents think it's this huge scope creep, which we can prove to you in the other state statutes and in Maryland, other comparable health occupations use the word prescribe. So if that's their one-word objection, we think there's absolutely zero merit to that objection.
Mr. Chair.
Delegate Bhandari.
Yeah, thank you, Mr. Chair. Dan, you specifically talk about one phrase if I heard your opposition correctly, that you also had the issue with the phrase practice audiology in the statute may limit the ability of physician and surgeon who are not licensed audiologists. Would you want to comment on that?
That was we understand now that wasn't the case. The full extent of the statute makes clear that other providers otherwise licensed wouldn't be prohibited. So that has been cleared up. And I think the reprint of the bill illustrates that. I think those lines were included to show that.
Thank you.
If I may go back to
very briefly.
Yeah. Okay. So in our reading of that FDA letter, and my understanding of the FDA rule is they were very clear. The FDA was very clear that what was previously prescription devices, or what was previously restricted devices, they're now reterming as prescription devices, and nothing changes in the states except for that nomenclature. So in looking at what was presented in the bill, what existed in law before is greatly different than what's proposed before us now. And I think that's what we're trying to look at and better understand. So,
okay. Mr. Wise.
Thank you, Mr. Chairman. Steve Wise on behalf of MedChi, the Maryland State Medical Society. Dr. Pryor spoke at the hearing on behalf of MedChi, you might recall. A couple of things. I have not seen the amendments that were discussed, but I will get with counsel to get those and digest those. I do not agree, based on what I've been reading here, that these changes are innocuous at all. If you look on page 2 of the bill, starting at line 15, which talks about ordering, evaluating, diagnosing, managing, or treating, those are the same words you see in the physician statute where the practice of medicine is defined. So at a minimum, you're setting up a situation here where it's going to be awfully hard to tell where the practice of audiology stops and the practice of medicine begins. I feel like the implementation of this rule for an over-the-counter rule from the FDA, I fail to see how implementation of that requires such a wholesale expansion of the practice of audiology. If it is indeed targeted to specific devices, the entire definition of practice audiology does not need to change. And that's what's in the bill in front of you. It needs to be a much more targeted change if that's all we're trying to accomplish. But I look forward to reading the amendments.
Mr. Chairman, may I have the?
No, you are not recognized.
Thank you.
Ms. Neal, I hope I'm pronouncing your name correctly. You can raise your hand.
Hi, I'm Dr. Earl. How are you doing?
Hi, sorry I didn't get it right.
It's okay. It's just initials.
Okay.
I was asked to talk from a surgeon's perspective on what it means to diagnose, treat, and manage ear and vestibular disorders briefly, just so that everyone has an idea of what it really means to do that and why we have such an issue with that kind of language that's being used in this bill. And so briefly, when I see a patient with an ear or a vestibular issue, it could be anything from an ear infection or down to a tumor in the ear, I have to be able to come up with a differential diagnosis. So that means I have to have a wide list of things that I could pick from in my head that this thing could be. It could, not everything is an ear infection, not everything is treated but easily with drops or cleaning. It requires me being able to order the correct studies to make the determination on what this is. And sometimes it requires that I take this person to surgery. I've had a long amount of training to be able to do this. I did med school for 4 years and then 5 years of a surgical training, including general surgery training. And I'm telling you, ear issues are not simple or easy issues at all. So of course, when I read that language, it is blurry or unclear how much audiology would be able to do, like how much, that would allow them to do. And I kind of worry that maybe we'll start to encounter delayed treatment or mistreatment that can progress to serious things like hearing loss or growth of a tumor that goes undiagnosed because you can't see it. You just have to know that that's what it is based on how it's presenting. So, I just kind of wanted to be able to share my perspective on how I see patients and what my concern is as a physician and a surgeon about the language that's being used to define what audiology can do. It really seriously mirrors what an otologist who is an ear specialist do. That is what they do with all their training and fellowship. They manage any disease of the ear and vestibular system.
Thank you very much.
Thank you.
Dr. Segev, followed by Delegate Bagnall.
Thank you so much. And I absolutely respect Dr. Neal's opinion there. And I would agree that audiology is definitely part of that best practice. And so what the first part of that differential treatment that she was referring to is going to be an audiogram, which is what an audiologist does. And if you're worried about a tumor, we can usually see signs of that based on the configuration of a hearing test, going through the case history with the patient, reviewing some of the symptoms that they're experiencing. And then what is best for that patient in our scope is to then refer to an ear, nose, and throat physician or back to their primary care physician for an MRI if we're suspicious of a lesion occurring, or back to the ear, nose, and throat physician if it's something that requires more medical management. So we are part of that differential diagnosis. And in our scope, we don't perform surgery. We do treat hearing loss with hearing aids. We can help manage tinnitus. If it's dizziness related symptoms, we do testing for that with a variety of test batteries that we perform in our offices, as well as then referrals to other specialists so we can really get a diagnosis for that or an answer for why these patients are experiencing these symptoms. Our referrals go beyond ENT, and we can refer back to primary care, pediatricians. We can refer to neurology, psychology, if it's managing tinnitus and other disorders. And, when we talk about these referrals and the patients we see, I'm going to say approximately 90% of them are the ones that we can manage in our office. And it's just routine hearing loss due to aging or environmental factors. If it is in the 10% of approximately these patients we see that do require medical treatment, we absolutely refer out. We want what is best for patient healthcare. So we are not changing our scope. We are just trying to be part of that team that can help manage these patients and your constituents so we can ensure their safety. We don't have no interest. We don't perform surgery. We are the audiology, we are the primary point for hearing and balance healthcare. And if we see red flags that occur, that is when we refer out back to our colleagues at ear, nose, and throat or other specialties. If it's a lesion on the ear, we refer to dermatology. So we're constantly spending time with our patients to be able to provide.
Thank you very much. Thank you very much. Delegate Bagnall, your hand is down. Do you still wish to speak?
I do. Thank you, Mr.
Sure,
Chair.
sure.
I'm just trying to sort of wrap my head around what we're talking about in this bill versus like the larger discussion of scope of practice, because my understanding is that this bill is to try and conform changes in federal law, try and conform Maryland law to changes in federal law. And the opponent's concern is that in the changes that we are altering scope of practice. So my question to the opponents is, do you have language or a path or concerns that we could address in the bill so that we can make sure that Maryland law is conforming to the federal changes, and therefore that there won't be a gap in services for our Maryland constituents?
Someone wish to respond to Delegate Bagnall's request? Ms. Brocato.
Thank you, Mr. Chairman. Thank you, Delegate Bagnall, for those comments, because I just am sorry to very strongly disagree with the proponents that this doesn't open up this practice of audiology to be able to do anything that an ear, nose, and throat surgeon does. That they may not want to, they may not do it, but
If I may, if I can interrupt, if I heard the delegate correctly, and I think this is where I'm headed as well, and I'm going to review the FDA letter after today's meeting and perhaps even get advice from the Attorney General's office in addition to counsel. But I believe Delegate Bagnall's question had to do with, does this bill conform to the FDA letter? Which it must, because it's a federal agency.
so to that question, Delegate Rosenberg, I think Mr. Shattuck has given you our read. We did reach out to FDA, haven't had any specific absolute response, but our read of that FDA letter is that there's no change in statute that's needed. Dan, I'm gonna punt back to you.
Mr. Shattuck, briefly.
Sure. I would just say that, the FDA throughout their guidance, FDA does not set scope of practice. They don't make those determinations. They talk about devices and pharmaceuticals, and they might say how they should be or could be used, but it's not a directive to the states. And again, I think that letter is very clear, saying we're not telling states to make changes. We're just saying this is how FDA, is putting forth its guidance. But it's up to the states to authorize who does what and how. So,
and I would add to what I said earlier, we are not limited to what the FDA says. We can go beyond if it is permitted. But I just want to have, for my sake and the subcommittee's sake, a better understanding of the FDA letter and this before we proceed any further. So we will resume this discussion most likely next week. And there being no further business before the subcommittee, is there a motion to adjourn?
Motion to adjourn.
Thank you. So moved. We are adjourned most likely until this time next Thursday. And I would just leave it at that. I'll leave it at that.